the last and very important case at this day. This is middle-aged female patient, 50-year-old, came admitted with history of syncopal attacks and unable to walk. This tachycardia, sinus tachycardia, and T-wave inversion and small Q wave in lead 3, inferior lead, with elevated ST segment at V1 mildly and T-wave inversion, similar to that of lead 3, and T-wave inversion in V1, V2, V3, V4, V5. This. She has chest pain. We were confused because the atypical presentation. Her blood pressure was 95/60. This is the echo, the flow through pulmonary artery, rapid deceleration time, and it is less than 60. And the flow in tricuspid valve also it's increased, but not more than 2.5, yani up to less than 60. This is called 60-60 sign, which commonly present in pulmonary embolism particularly when the right ventricle is small and adapted the high pressure. We initially treated her as ischemic heart disease because the inversion of T wave here and mildly elevated in AVR, but the second day the patient condition is deteriorated, and then we repeated the echo. We saw the embolism at the pulmonary bifurcation. Then the patient is kept on heparin and warfarin and vasopressor such as dopamine. This is the EKG at the second day with Q wave in inferior leads, lead 3, and T wave inversion and ST segment elevation, and MV1 with relatively the heart rate here is less than the first day. And this is the EKG of the third day. Look here, the right ventricle is start to dilated and prominent R wave in V1 with T wave inversion and normal axis, but the lead 3 inferior leads exhibit ST segment elevation, this and small Q wave. And this is the EKG, the last ECG, this which return to the normal, but after the patient referred to Sana'a and they did for her their CT angiography, the embolism was clear there, and they kept her on the anticoagulant treatment, and the patient is returned to normal after 2 months of treatment. The interesting thing here is when we reviewed the most of ECGs of pulmonary embolism in the textbook of cardiology and ECG, we were find that this bacular change, particularly in lead 3, look carefully, the small Q wave and ST segment elevation and T wave inversion with changes in V1, V2, V3 are identical in many of textbook of cardiology and ECGs. Yes, as you know, we understand that this ECG change is indirectly caused by dilated right ventricle, particularly the right ventricular outflow, but surprisingly the similarities of restricted to pulmonary embolism or more specific in pulmonary embolism, inferior interior ECG change, and the second female also seen with a pulmonary embolism. Yes, this is the EKG, and look here at the inferior lead This is lead 3. It has small Q wave and ST segment elevation and T wave inversion. This another female patient with a pulmonary embolism, and the embolism, other embolism, left embolism is shown inside the right ventricle. This is V1, similar to that of lead 3, and this is V2, V3, similar, with similar clinical presentation, approximately similar to clinical presentation of the first case. She was unable to move or to walk because the tightness of the chest. In their presentation, those two cases, they differ than that of ischemic heart disease, and they commonly unable to walk, and they carry them on their shoulders, the relative. Yes, these two cases are typical cases. The second case, she didn't do an CT angiography, and they admitted to hospital for 2 weeks, then they discharged. Thank you for your kind listening and watching.